Alright, so when we left off, I was telling you that the two things that we need to overcome in order to have airflow through the lungs is that we have to overcome airway resistance and elasticity of the lungs. So right now I'm still on overcoming resistance, and I'd like to focus now on the chronic obstructive pulmonary disease or disorders, and the big trifecta or triad includes asthma, chronic bronchitis, and emphysema. And just to remind you from our first segment, all three of these are a problem with expiration or exhalation or gas exchange. And again, we recognize there can be a problem with obstruction in the lumen or inflammation, hypertrophy, and even collapse of alveoli leading to diminished surface area. So it can be within the lumen, the air passageway itself, or collapse, destruction, and enlargement of air spaces. So bronchitis is going to be an issue with excessive mucus production, and there also can be hypertrophy, and this is basically going to lead to less surface area for exchange of oxygen. Asthma is an inflammation response. We're going to see IgE, we're going to see histamine being released, we're going to see fluid from the blood vessels leaking into alveoli, and this too is going to lead to less surface area for gas exchange. And then finally, emphysema, we're going to recognize that having fewer alveoli that are larger but fewer, does not mean more surface area, but in fact less surface area for gas exchange. And we'll also see that the lungs in a patient with emphysema are overly compliant. And this means that work of breathing is going to focus on exhalation, which should be a passive process to begin with. So let's start with asthma first. Asthma is pretty interesting. There is an idea that something called the hygiene hypothesis that can help explain the prevalence of helper T cells, the type 2 helper T cells seen in asthma patients. So I'd like to cover that first and just right now. So the hygiene hypothesis in asthma patients really comes down to what causes asthma. We really don't know. There's a lot of conjecture out there. This is what we do know. Remember your T4 cells, the CD4 cells, the cluster of differentiation. T4 cells are also called helper cells, and there are two types of T4 cells. One is the type 1 helper T cells, and the other is the type 2 helper T cells, where the H stands for helper cell and T stands for T cell. When you read it in the literature, they say Th2 or Th1. Now, remember what helper cells do. They help with clonal selection. Remember, they combine with the B cells that have the antigen on it, and the clonal selection occurs, and we make plasma cells and memory cells. So the plasma cell is like a factory, remember. It's the one that cranks out a lot of antibodies, about 2,000 per second. Okay, so why the difference between Th1 and Th2? So Th1, the Th1 helper T cells, class 1, they're going to turn the B cells so that they produce antibodies like IgGs and IgMs. So if you have a lot of Th1 cells in the body, then you get a lot of IgGs and IgMs. If you have a lot of Th2s, then you get a lot of IgEs. And anytime you see IgE, what comes to mind for you? For me, I think of allergies. I think of histamine release. I think of anaphylaxis. These are all associated with IgEs. The ideal balance that individuals have is that there's a normal balance between these two types of helper T cells. We want both. We want our IgEs, IgMs, and so forth. What they're finding in children is that sometimes this balance doesn't occur correctly, and a child may end up with elevated numbers of Th2s. And they're calling that a precursor to developing asthma. When you have a higher percent of Th2 cells making IgEs, now how would a child wind up with that, if that's what we're talking about leading to asthma? This is the hygiene hypothesis. If a child raised in a certain environment, a clean environment, let's say, they go to day school, the house is clean, they don't play in the yard or with other kids, no pets, they sit at their computer from the time they are 2 or 3 years old, they're not outside getting dirty. They are not exposing themselves to the allergens and antigens in the environment. The Th1, remember the one that stimulates the synthesis of IgGs and IgMs from the B cells? They are the ones that are going to guard against bacteria and fungi. Now, how do you make a lot of Th1s and IgGs and IgMs? You have to get dirty. You got to get exposed to the antigens that will cause the Th1 level to go up. What throws the balance off in an asthma patient is that not that they make more Th2, it's more that they make less Th1. And less Th1 means that they are going to crowd the helper cell population with these IgEs. So less Th1 means proportionately more Th2, and this leads to more IgEs. And now what you see with asthma, you see a lot of allergic responses to dust, dust mites, etc. And they have a greater number of cells reacting. This hypothesis is one of the newer ideas because there is an increase in asthma. And scientists, researchers, physicians say they may grow out of it when they get a little older, for example, go to kindergarten. But kids that grow up in a sterile environment, that is not good because that is not the way our immune system works, right? Why is it that our immune system is called the acquired immune system? Because we got to acquire it. Now, this is just one theory. Another is that some children are predisposed to make more Th2. Okay, so I'd like to go through some asthma up close now that I've told you about the hygiene theory. So as I said, it's the helper T cells, type 2, that stimulate the B cells to make more IgE, according to the hygiene hypothesis. Now, IgE is associated with allergies, as we've learned, and asthma, and the stem of the IgE anchors to a mast cell, which is a specialized white blood cell. And when an antigen or allergen comes along and binds to the IgE, this will lead to a bridge formation, and this causes the mast cell to release copious amounts of histamine. Histamine makes blood vessels dilate and leaky. We know this, so we get arterial dilation, we get changes in Kf. And this causes edema locally or even systemically. Inflammation alone can narrow airways, as we're seeing in this asthmatic bronchial on the right-hand side. Mucus production also narrows the air passageways. So these signal molecules trigger bronchial constriction as well, known as bronchial spasm, and you see that in the picture to the right with the bands of smooth muscle going around the air passageways, squeezing. Now that's going to further exacerbate things and narrow the air passageways even more. So what's the treatment? Obviously, we can give anti-inflammatory drugs. We can give glucocorticoids. That comes in an inhaler these days, your long-term inhaler, not your rescue inhaler. We can give beta-2 agonists like albuterol, which will stimulate the beta-2 cells, or receptor, and then the smooth muscle cells will relax. We can give parasympathetic inhibitors. We can give muscarinic acetylcholine receptor inhibitors like ipratropium. Now, I don't know if you've ever had an asthma attack, but it's horrendous. You hear crackling sounds and distant breath sounds because the air is slowly percolating out through these obstructive air passageways. And there is forceful coughing, trying to help with expiration. Now, I've been coughing ever since I came back from my walk with my dog, and I think I'm having a mild asthma attack. I get this way when we have bouts of lots of fog followed by dry weather, and then lots of fog and dry weather again, which we've been having here in Orange County with the heat wave. You know, here it is the end of October, and it's really, really hot out this weekend. So I think I'm having a mild asthma attack, which is why I'm coughing so much. I'm trying to get the air out. Now, what about chronic bronchitis? What is the definition of chronic bronchitis? Well, this is an inflammation of the air passageways, and it has to last for 3 consecutive months and then have bouts of these 3 consecutive months worth of chronic bronchitis for 1 year, and then have it happen for 2 consecutive years. So you have to have multiple infections within 1 year and then repeat this for 2 consecutive years. So it's a thickening of the air lining. We have hypertrophy. It's going to go into the lumen. We also have excessive mucus production. If you look here at the bottom right picture, you see severe hypertrophy of the lumen wall going towards the lumen, as well as excess of mucus and phlegm in the alveoli and air passageways. These patients will need an anti-inflammatory drug. They're going to need to take their antihistamines, and we call them the blue bloaters or the non-fighters. And this is because they can't change or alternate or modify in any way their respiratory rate or rhythm. How deep do they take a breath in? Do they focus on inhalation or exhalation? Nothing they do will change the fact that their lumen wall has hypertrophied and they have excess mucus. There can be no changes in their breathing to compensate for that. So that's why we call them blue, because they're going to be cyanotic. And we call them bloaters because when there's excessive CO2 trapped in the alveoli, CO2, I have to tell you, works in a different way in the lungs than it does in systemic blood vessels. Remember, in systemic blood vessels, we learned that CO2 acts as a vasodilator. Well, excessive CO2 in the bloodstream, hypercapnia, leads to vasoconstriction. If it could talk to you, it would say, now why would we want to bring blood to an alveolus if the blood has a lot of CO2? Because then we're not going to get as much CO2 from the blood to leave into the alveolus, because there's a lot of, there isn't as great of a concentration gradient, especially if we talk about CO2 being trapped in the alveolus to begin with because of the excessive mucus. So there's vasoconstriction instead of vasodilation. And this means that with the excessive vasoconstriction, the right side of the heart now has to work extremely hard to overcome that pulmonary hypertension. And this can lead to right ventricular hypertrophy and right ventricle failure. And that means the right side of the heart is not acting as a good pump. And this means we can end up seeing systemic edema, particularly in the fingertips of these patients. So I said this before in another lecture, they look like they're tree frogs with these large bulbous fingertip edges. Now, with time, the kidneys are going to sense hypoxemia, and they will release erythropoietin, and this will provoke polycythemia in these patients as an effort to have more red blood cells to bind to more oxygen. And one of the signs that you'll see in a patient with chronic bronchitis is excessive coughing and shortness of breath, or dyspnea. Now I'd like to tell you about the pink puffers, referring to patients with emphysema. They are also referred to as fighters, and the reason why they call them fighters is because emphysemic patients can overcome the drop in pressure. They have to create more pressure to bring air into and out of the lungs. So let's look at emphysema and why they're called pink puffers. If you think of your alveoli, and there are different sizes and connections they have. Emphysema is an expansion of alveoli. So you have fewer of them, but they're larger. So the radius is going up, and I'm going to tell you about the law of LaPlace pretty soon. But an increase in the radius of alveoli actually leads to a decrease in surface area. Here's what I mean. The normal lung may have about 100 million alveoli in each lung, and the emphysemic lung may have maybe 50 million in each lung. And the alveoli are larger, which makes them less efficient. So you're losing alveoli, and you are becoming a big air sac, a big balloon. And the reason for the loss of the alveoli, okay, so maybe you need an analogy of why bigger but fewer alveoli is actually a loss of surface area. All right, so one of my good friends, her name is Diane, she likes to paint. She's an impressionistic artist. And every once in a while she likes to have people over to her house so she can show off her artwork. Now, a whole bunch of people show up for these art showings, and she hangs her paintings on the walls all throughout her house. And it's a good time, and we're milling around, and we're looking at her paintings. And every once in a while she'll say to me, Kara, I don't like how crowded it gets during my showings, so I'm thinking of pushing down a wall or two and really opening up my living room. And I look at her like she's crazy. Now, she has lots of small rooms with narrow passageways, but if she knocks down walls, yes, the room will get bigger, but what will happen to the amount of walls she has to hang her paintings on? She's going to have fewer of them, right? So let that analogy represent that if you have fewer alveoli but they're larger, you are actually missing wall space for gas exchange. Okay, so let's get back to why do we have this breaking down of the walls between alveoli. It all comes down to a protein called elastin. Elastin is a protein that holds alveoli together. Elastin is the protein that gives the alveoli rigidity and keep them open. And then you have enzymes called proteases. Proteases like elastase will destroy elastin. Elastase is a normal component of the lysosome, especially the lysosomes found in macrophages. Remember the macrophage with all the lysosomes in them? They give off, inside the lysosomes, they've got these hydrolytic enzymes for destruction of the bacteria, remember? Well, one of these types of proteases will also destroy elastin. So in an emphysemic patient, you've got too much elastase, destroying too much elastin, which causes these alveoli to fall apart. One of the interesting things about these proteases is that you sort of have a game going on. The proteases can destroy the proteins, but there are also proteins that can destroy the proteases. One of these particular proteins is called antitrypsin. These are anti-proteases. So antitrypsins are also produced by macrophages, and you should have this balance. You've got the enzyme that will destroy the proteins, and you've got the enzymes that destroy the enzymes that destroy the proteins. That's the balance. The problem with the antitrypsin is that with some emphysemic patients, there's a genetic fault, and they don't produce enough antitrypsin. So with this decrease in emphysemic patients, then you have elastase destroying the elastin. Generally, the cause of emphysema is a lack of antitrypsin, and there is a lab test for antitrypsin. So if your antitrypsin is low and you are showing respiratory distress, then you are probably a pink puffer. So it is a genetic predisposition, or it could be because you're smoking. Smoke will bring more macrophages and release more elastase. So if you want to increase your elastase, smoke. Once those alveoli are gone, however, they are gone for good. But if you stop smoking, you stop the destruction. but the damage already done with lots of larger alveoli and fewer smaller alveoli is irreversible. Some people smoke and never get emphysema. Some smoke 6 cigarettes and get it. Again, there's a genetic level to it as well. So the elastic components are lost. The lung is easily inflated. There's a barrel chest. It's overly compromised. It's overly compliant, I should say. And the recoilability is compromised. So the chest is winning. The chest gets to go outward. Now, why do they call them pink puffers? Well, they bend over. They take a tripod stance. They put their hands on their knees. They're going to recruit their abdominal muscles to push on their abdominal contents to help push the diaphragm up as high as possible. And then they're going to purse their lips together like they're blowing through a straw. And this builds up resistance, right? You're creating a longer air passageway. According to Poissouillet, the longer the passageway, the more resistance. So it builds up back pressure, and this might be enough to open up those normally collapsed bronchioles that collapse during a normal exhalation. Now, how can we treat these patients? Well, if they have advanced chronic obstructive pulmonary disease and they need a lung transplant, well, we can do that as well. We can also do a bulectomy, and a bulectomy, I'm showing you a bulla down here in the bottom picture. It is just a large distended area of the lung, and the bulectomy is a surgical procedure that involves the removal of that bulla or bulli, which is plural, and that compresses on adjacent lung tissue and can cause dyspnea or air hunger. And like I said, lung transplantation is becoming an alternative treatment for persons with severe lung disease. There's limited life expectancy without transplantation. And you'll soon find out or remind yourselves that with the lungs starting to fail, we also see other organ systems like the renal system also starting to fail. And this mostly will be due to trying to maintain acid-base balance. Okay, so we just covered overcoming the obstruction of air passageways. The other part of the work of breathing is overcoming the elasticity. So there's a fine balance between elastic recoil, wanting to go back to its original shape, versus compliance, which means overly easy to stretch, as seen in the case of the barrel chest in the patient with emphysema. So too much or too little recoil versus compliance can be, disease states. We want a set point. If there's too much recoil, that could be because of surfactant lack. It also could be because of replacement of elastic tissue by collagen tissues. In the case of excessive compliance, that would be a perfect example of emphysema, where the alveoli have been destroyed, the elastin has been destroyed, so we don't get the recoiling, just the stretching. Okay, so the lung, what determines compliance in the lung? Two things. The elastic fibers, of course, but they only account for 1/3 of lung compliance. The elastic fibers, of course, allowing for the stretchability. But for compliance, not only do we have to overcome the natural recoil of those elastic fibers, but we also have to overcome the surface tension. The inside of the lung, of course, is moist. There is water in there. And we find that the water inside the alveoli contributes 2/3 of this, not elasticity necessarily of the lung, but the tendency to recoil, I guess is what I'm trying to say. So this is because of surface tension, the attraction of water molecules for each other. This is going to be a cohesive inward force. If you think of the alveoli like a contact lens, if you were taking a contact lens off your eye and you squeezed your contact lens a little bit too hard, such that the two edges collapse on each other, so you get this half moon or taco-like appearance of your contact lens, you're not very happy, because you will have to use great force trying to overcome the cohesiveness of the water trapped between the two flaps of the plastic. And then once you do, 9 times out of 10, you rip that contact lens in half, and then the expletives come, right? So the surface tension, wanting to have the water attracted to each other at the level of water versus air interface, we need to overcome that surface tension, because it's going to be an inward force, like I said, that's going to cause the alveoli to collapse. Okay, so this is redundant. How do we change the lung compliance? We need to disrupt the surface tension. We need to have a detergent-like molecule known as surfactant to disrupt that surface tension. We also want elastic tissue, but the recoilability means that we have to overcome that. If the elastic tissue is replaced by collagen fibers, there will be even more problem with getting them to stretch. Collagen does not stretch very well. So if compliance decreases, meaning it's harder to stretch the lungs when the respiratory muscles are contracting, then that means the respiratory muscles are going to have to do more work to expand the thoracic volume to get the lungs to reach a given volume. And the other way we can change compliance or have it be altered is through the interdependence of alveoli, which I'll show you in just a moment. So what do I mean by interdependence of alveoli? Well, in the top picture here, you're seeing terminal bronchioles leading to respiratory bronchioles, leading to alveolar sacs with alveolar ducts leading to alveolar sacs, which is like a cluster of grapes. But I have to tell you, I've read lots of physiology papers about teaching physiology, and they all say a true good physiology teacher should not be using the analogy of grapes for alveoli, because grapes are independent spherical structures and alveoli are not. They're interdependent. Well, I understand that, but they still look like a cluster of grapes to me, so I think it still applies. As long as I tell you that they are not distinct entities. If you look at the bottom right picture, you see these interalveolar pores, and this means that air can flow from one alveolus to an adjacent alveolus without having to go back out to the atrium of an alveolar sac. They don't have to go out into the main air passageway. So this interdependency means that when one alveolus inflates, it will help a neighboring alveolus to inflate because, of course, air will flow from high pressure to low. The loss of alveolar walls means that we're going to lose surface area. We've already addressed that. But we're also going to lose this interdependence, which means we're going to see a greater tendency for alveoli to collapse, which means atelectasis. So if you want a demonstration of surface tension in water, you can do the following little experiment. If perhaps you're drinking some water right now, or even a soda, go ahead and put a drop of water on your thumb, and then take your index finger and smash that water onto your thumb. Now pull your two fingers apart, and you should see that droplet of water being stretched. And you can actually separate your fingers quite a distance, and it thins out quite nicely. It almost looks like an hourglass the more you're pulling on your fingers, until finally your strength outmatches the surface tension of the water. So that explains the cohesiveness of water. Water, of course, is somewhat polar. It's got a very electronegative oxygen atom and two somewhat positive hydrogen atoms associated with water. And so these water molecules can orient their hydrogen poles to their oxygen poles, or positive poles to the negative poles. Basically, it means that there's a resulting vector force that translates into favoring alveoli to collapse, meaning an inward collapsion. And surfactant is going to be a natural detergent-like substance that we make to disrupt the surface tension. Alright, so what is surfactant? Well, one of the big contributors to surfactant synthesis is a molecule called dipalmitoyl lecithin. And dipalmitoyl lecithin is shown up here as a picture in the top right of your screen. And if you look on the right side, you see a phosphate group and a nitrogen group with lots of methyl groups. And what I'm trying to show you there is that the phosphate group is negatively charged, and that nitrogen has 4 bonds to it, so it's positively charged. So we have like a head-like structure that makes this molecule hydrophilic. That's the hydrophilic part. Now if you look at the top part where it has 2 chains of CH3 parentheses, CH2 to the 14, and then a carboxyl group, what that's really showing you is a long hydrocarbon chain. And those long hydrocarbon chains are going to be your hydrophobic region of the molecule. So we say that this molecule is amphipathic, which means it has both polar or water-loving parts and nonpolar, which means hydrophobic or water-hating parts. So this dipalmitoyl lecithin will combine with other proteins and salts to make surfactant proper. It's a detergent-like substance. Detergents do have amphipathic properties. Some part of them, like water, and others don't. So they will orient themselves, these molecules, such that their water-loving components faces a water environment and their water-hating components face away. So this surfactant will become interspersed in the water that lines the alveolar walls and will allow the water molecules to separate. This lowers their cohesion, so surface tension is reduced. I'd like to tell you about LaPlace's law. Okay, what is LaPlace's law? You know what? The first thing an instructor does when they're talking about the pulmonary system is that they should go through the gas laws a little bit, because you never understand breathing unless you understand Boyle's law. Breathing is a simple example of Boyle's law of respiration. Boyle's law is that pressure and volume are inversely related. With an increase in pressure, you're going to have a decrease in volume. With decrease in pressure, you're going to have an increase in volume. And well, when it comes to breathing, we work on the volume changes first. With an increase in volume, thoracic expansion, we have a decrease in pressure inside the alveolus. And so air flows from the atmosphere into our lungs. So that's Boyle's law, and explains why we can get ventilation. When the chest musculatures, like the diaphragm and external intercostals, are allowed to relax, chest wall volume decreases, and this means the pressure inside the alveoli goes up. Well, now I should tell you about LaPlace's law, now that I've introduced or reminded you of Boyle's law. The law of Laplace says that pressure is equal to 2 times the surface tension over the radius. If you remember in the lungs, and this is where surfactant comes in, you've got the alveoli, and they come in all different sizes. Radius is not uniform. And therein lies the problem, because you may have the end of a bronchus where you have a small alveolus, and then at the other end a large alveolus, which I've shown here in this picture as alveolus A and alveolus B. Alveolus A is clearly larger than alveolus B. And this is very common in your little grape cluster like scenario of alveoli in an alveolar sac. The problem with it is you've got air pressure in both alveoli. And if you go to the law of LaPlace, it says that if the radius goes down, then the pressure is going to go up. So let's take this example where here the pressure should be elevated in the smaller alveolus, alveolus B, and over here the radius is going up. So the pressure is going down. That's the larger alveolus. So that means at the large alveoli you would have less pressure than what you would have in the small alveoli. And since they are connected, remember, through their interalveolar pores, the high pressure would push air from the high pressure alveolus, alveolus B, to the low pressure. And that means alveolus B would immediately collapse. And all the small alveoli would collapse. And all the large alveoli would get larger. Not a good system because you depend on that surface area. If you did a lateral slicing through a pair of human lungs and took out all the alveoli and spread them out, the size of the lungs would be, or I should say the surface area within the lungs would be the size of a tennis court. And that is the actual area for the respiratory gases which move between the alveoli and capillaries. That much space is needed. If all the smaller alveoli collapsed into the larger alveoli, you would lose a large part of your surface area for gas exchange. So, do you remember which cells in an alveolus makes surfactant? We have type 1 cells and we have type 2 cells. And let's go through those again. Okay. So type 1 cells are the simple squamous epithelium, and type 2 cells are the cells that are actually making the surfactant. So like I said before, water gives you this cohesion. And remember from anatomy that during inhalation your alveoli have to expand, and during exhalation they compress. Does the inhalation cause the expansion? No. The expansion causes inhalation. We are not vacuum cleaners, remember. We obey Boyle's law. So we change the volume, change our thoracic cavity, and then reduce the pressure in our lungs, and that's what draws the air in. So we don't have to suck air. The problem does not occur in inhalation when we get the expansion of the alveoli. The problem occurs during exhalation. Think of my hand as like an alveolus, and of course the smaller alveoli, the greater the compression you're going to have, right? Because they're the tendency for them to collapse. So I'm holding my hand like a C, like a contact lens. So now I want you to think of the following scenario. So remember me saying get a drop of water and put it on your thumb, and then try and put your index finger over that drop of water, and then separate your finger and your thumb, and you can see the water starting to slim out and kind of have an hourglass appearance. Well, if you keep moving your fingers apart, you break that surface tension. Okay, so now think of your hand as a C, and instead of your index finger and thumb, think of it as a contact lens with water in between the two flaps. Well, as you start to pull, there's going to be surface tension. And with you trying to open a contact lens, yes, you can overcome that surface tension. But let's say you're talking about an infant with 100 million alveoli in each lung, and each one of them has that surface tension. Well, that infant is going to have a hard time trying to open up all of those alveoli. That child is going to have to generate a greater pressure gradient by causing greater changes in thoracic volume. So you'll see an infant with respiratory distress syndrome, and it's because they don't have enough surfactant. So with every breath in, they have to use a greater force to cause greater changes in their thoracic volume to try and cause greater pressure changes to open up all of those alveoli. So this is called infant respiratory distress syndrome. There is an adult respiratory distress syndrome, but this is damage to type 2 cells. So the adult has basically killed off their type 2 cells through smoke inhalation or positive pressure breathing. But they used to have enough surfactant and now they don't. So the nice thing about surfactant is that in each alveolus, the number of type 2 cells and the amount of surfactant made is actually the same. So why is it that surfactant will actually cause smaller radius alveoli to open up and be more compliant when it's the same amount in alveolus B shown here as it is in alveolus A? And it comes down to, well, if they have each the same number of surfactant molecules, but B has a smaller volume, then that means the surfactant will be more concentrated in alveolus B than in alveolus A. And this means more help to alveolus B to inflate and be distensible on the next breath in. On Blackboard, I did upload a paper called Babies and Surfactant. It's an amazing story about how a scientist and a physician were on the path trying to find out what was wrong with infant respiratory distress. But back then they called it hyaline disease because they really did think that it was cartilage inside the baby's lungs because their alveoli were not open as well. So surfactant is made between 26 to 28 weeks of gestation and then throughout life. And if we're worried about a mother having preterm labor and delivery, we can do an amnio and a sonogram, and this test is called the LS ratio. It stands for lecithin to sphingomyelin. The sphingomyelin is a constant component of amniotic fluid, and the lecithin, as you learned, is part of the surfactant, the dipalmitoyl lecithin. So when the lecithin levels rise to a level of 2 or higher, that means their ratio is 2 or more above sphingomyelin, then that indicates that there is production of surfactant and the baby's lungs are mature. If the baby's lungs are not mature, they can give steroids to the mother to help the baby's lungs mature more quickly. And the reason for the glucocorticoids is discussed in that paper I said that I uploaded on Blackboard. I highly recommend you read it. We also can give exogenous surfactant. We have artificial surfactant, and I'd like to tell you about that now. What they do is they take this substance, this powder, this artificial surfactant called ExoSurf. Stands for exogenous surfactant. It is a white powder, and when the baby is born, they take this dissolved powder, turn the baby on its side, and pour it into the trachea, and let it sit in that lung for some time. Then they turn the baby over and do the same intubation and insert the ExoSurf into the lung, which helps coat the inside of the lung, and this becomes the baby's artificial surfactant. ExoSurf works for about 4 weeks, and once that baby is born, even if it's a preemie, those type 2 cells will eventually switch into gear and start cranking out surfactant. It's like they're saying, oops, we are late, and they really start flooding the alveoli with surfactant. That is why the baby won't need additional ExoSurf at that point. Natural surfactant works much better. ExoSurf is still somewhat experimental. Now, what about adult RDS? And why would you suddenly lose your surfactant? Well, the most common way to lose surfactant is caused by aspirating vomit, if you can imagine. Not so much, smoking also causes adult respiratory distress syndrome, as I said, but aspirating vomit of all things. Sometimes if you get the gastric aspiration in the trachea and down into the lungs, it will just burn off that surfactant. They have been experimenting with the ExoSurf on adults, and it is not working as well as it does with children. They use the natural surfactant as well, and they can isolate that from infants that have died. So surfactant isolated from adult or surfactant isolated from infants, same. Can be used in either adult or child. Brush fires can also cause loss of surfactant, especially in Southern California. There's the creosote bush, I think that's how you say it, or creosote bush, which causes black smoke when it burns and can cause a tremendous amount of lung damage. The problem with the creosote bush is that the damage is usually permanent, where with a gastric aspiration, it's temporary. You can also lose surfactant, and this is interesting, through near drownings. There are two kinds of near drownings, seawater and freshwater. Seawater is 3% sodium chloride. Let's say you have a near drowning in seawater. You always look at the alveolus. Coming into the alveolus, because you've just inhaled water, is 3% salt in seawater. That means you are bringing in 97% water. In your plasma, of course, you only have 0.9% sodium chloride. That's the normal value for salt. So you have 99.1% water in plasma. Then you're going to have osmosis occurring. Remember, osmosis is always a high concentration of water moving to a low concentration of water through a cell membrane. Well, here is your high concentration of water in the blood because it is 99.1% water. So the direction of water movement in near drowning incidences in seawater is you're going to move the fluid from the capillaries to the alveolus. That is why it is much more dangerous for near drowning in seawater than freshwater. If you rescue somebody and it is a near drowning, transport them to the hospital and make sure that water isn't continuing to move down to lower water content in the alveoli. That flow of water coming across the capillary into the alveoli or alveolus pushes the surfactant out. So not only are you filling the alveolus with fluid, you're also taking away the surfactant. So once you drain them and they start breathing again, when you have gotten the fluid out, their lungs can collapse due to no surfactant, and they could die 3 or 5 hours later. Now what about fresh water? You still have sodium chloride, but it is like 0.1%. That would make the water it's dissolved in 99.9% water. And again, osmosis. You're always going to go from high water content to low water content. And so now you've just inhaled 99.1%, and you've just inhaled water that is 99.9%, and your blood has 99.1%. You're still going to have fluid shifting, but this time from the alveolus to the plasma. And it's safer than the seawater because the patient could likely live. I mean, you're basically going to be dealing with maybe dilute sodium levels and calcium levels in the bloodstream, but that's going to be transient. So eventually your lung will take care of itself and dry itself out from the fluid that you've aspirated. And the surfactant will remain. So not only does the patient recover faster, they probably won't have the adult RDS that you might have thought. So considering what we were talking about with the body temperature in freshwater and seawater, what would be the worst situation? Warm seawater. Tropical seawater is the worst possible near drowning. Because remember, if it's cold, you have less oxygen demand and you can shut down a little bit. If you have warm water, metabolic rate goes up, and warm water means that you are going to consume more oxygen, and if you're drowning and you're underwater, that means the oxygen that you have as a reserve in your bloodstream is being used up more readily. So warm seawater near drowning is by far the worst situation.